I'm Dr. Heather Leary, and I'm going to give a short presentation on chimeric antigen receptor, or CAR-T therapy. I will cover a short background of CAR-T therapy, what it actually is, the current and potential future uses, and some of the key side effects of the treatment. So this picture is Emily Whitehead with Dr. Stephen Grupp. In early 2012, Emily was 6 when she was diagnosed with an aggressive relapsed acute lymphoblastic leukemia. Her local hospital has advised there was no further treatment for her and they should take her home to die with her family. They sought an opinion from Dr. Grupp, who was just about to open a clinical trial in children with relapsed acute lymphoblastic leukemia. Emily was the first person to enrol in the clinical trial, and although she had a challenging clinical course with lots of toxicity, she remains in remission 12 years later. A definite success story. CAR-T was first developed in 1987. And the process of developing the product has been refined over the next 20 years. The first clinical trials happened in 2006 and were given to patients with chronic lymphocytic leukemia. The first product, Kymera, was approved in America in 2017 for children with acute lymphoblastic leukemia. In the NHS, we now have a number of CAR-T products available for patients with B-cell lymphomas, and there are clinical trials in multiple myeloma. So what exactly is CAR-T? CAR-T cells engineers patients' own T cells to identify cancer cells. Our T cells are a natural part of our immune system and play a key role in fighting infections and in the immune surveillance of cancer. However, cancer cells can hide from T cells, and this is one of the mechanisms of how they grow and how they become resistant to chemotherapy. The idea of the CAR-T is that you take the patient's own cells and genetically modify them to express a specific antigen which can then bind to the cancer cells, activating cytotoxins and leading to cell death. In order to make a CAR-T product, the patient's own cells are first collected via leukapheresis. These are then sent to the CAR-T lab, and there is a gene transfer using a lentivirus gene which makes the T cells produce the additional antigen. The T cells are then produced in the lab, and then they're grown and stimulated to form enough T cells to be able to give back to the patient. Patients receive lymphodepleting chemotherapy prior to their CAR-T cell infusion and are then given the infusion of the CAR-T cells. I'm going to talk a little bit about the pathway for our local patients. Our local referral centre is Oxford, and we have an MDT meeting with Oxford on a Wednesday. Patients are identified as potentially suitable for CAR-T, and the aim is that they will meet the team in Oxford the following Friday. All patients who are receiving CAR-T need to be discussed at a national expert panel to ensure the treatment is appropriate and within the national guidelines. Patients will also need to undergo further workup tests to make sure that they are suitable for CAR-T, including blood tests, echocardiogram, and sometimes lung function. Patients' stem cells are collected at the NHSBT apheresis centre in Oxford. It's a very similar process to collecting autologous stem cell transplants, but usually takes a bit shorter and should be done within 1 day. The CAR-T cells are then sent to the company laboratory, and this takes around 4 to 6 weeks for the product to be made. During this time, almost all patients will require some form of bridging therapy, which may be in the form of chemotherapy or radiotherapy, and we would be giving this locally. Patients then have a repeat PET-CT scan just prior to their treatment, which is usually done in Oxford. We would hope that patients will be in as good a remission as possible prior to their admission for CAR-T. Patients are admitted 6 days prior to their CAR-T infusion, which is known as day 0. They are given lymphodepleting chemotherapy, and the exact type of chemotherapy varies on the CAR-T product and the disease being treated. This is quite similar to, for example, a beam autograft. CAR-T cells are infused on day 0, and then patients have a period of time recuperating in hospital. They spend the first 14 days as an inpatient in hospital in Oxford, and then have to spend the next 14 days up to day 28 as close to Oxford as possible. There is a flat available our patients can stay in for this subsequent 14 days, and they need to be within an hour of Oxford and with someone who is able to drive them if they need to be seen routine, in a review, or as an emergency. So why might we be using CAR T? So CAR T is funded by the NHS in adults with diffuse large B-cell lymphoma who have relapsed after at least 2 different treatments, adults with diffuse large B-cell lymphoma who've had 1 treatment and whose their next treatment would be an autologous stem cell transplant. It's also licensed in patients with mantle cell lymphoma after 2 treatments, and in adults and children with B-cell acute lymphoblastic leukemia, which is relapsed after first-line treatment. There are clinical trials in multiple myeloma, which are looking very promising, and I suspect this is coming our way soon. There are also clinical trials being conducted with allogeneic CAR T cells, which would be taking them from, for example, a sibling and manufacturing them in the same process. CAR T is also being investigated in solid organ cancers, but these have shown less promise so far. So, just to explain some of the rationale behind CAR T treatment in diffuse large B-cell lymphoma, as this is by far the commonest patient group you'll be looking after. So previously, patients who relapsed after R-CHOP would be referred to have further chemotherapy and then an autologous beam stem cell transplant. In the clinical trials, this cured maybe 30 to 40% of patients who received the treatment, but you have to be fit enough, and unfortunately a large number of patients died before they were able to be given the beam autograft treatment. Additionally, if the diffuse large B-cell lymphoma relapsed within 12 months of an autograft, only around 20% of patients were still alive at 2 years, and the average life expectancy at 6 months. So this was really a very dire prognosis. CAR T has improved this somewhat, and in the clinical trials, around 40% of patients remain in remission at 24 months. As you may be aware, we now have additional treatments for patients who have relapsed post-CAR T in the form of glofitamab, which also gives remissions in around 40% of patients. So we're still not there yet, and this is still a very high-risk disease, but CAR T has certainly improved things compared to our previous treatment. So what are the side effects of CAR T? So acutely, the main side effects are cytokine release syndrome, neurological toxicity, and the toxicity related to the lymphodepleting chemotherapy, which again is similar to an autologous stem cell transplant, but probably a little bit less severe. Cytokine release syndrome, you may be familiar with this table, as we use this for our patients with glofitamab. Cytokine release syndrome is essentially an inflammatory response caused by the release of cytokines, which are part of the body, something the body produces in order to kill bacteria and also cancer cells. Grade 1 is simply a temperature of over 38 degrees. Grade 2 is a temperature of 38 degrees with a drop in blood pressure or a small amount of oxygen requirement. More serious would be grade 3 and grade 4, which is a temperature, and then patients may require intensive care support for vasopressors for low blood pressure or high flow oxygen or mechanical ventilation. Cytokine release syndrome can be treated with tocilizumab in CAR T in a very similar way to how it would be treated for our patients having glofitamab. Neurological toxicity is more common in CAR T patients than in patients receiving glofitamab. We don't really know why it occurs. Patients can present with confusion, or they may simply be more sleepy. Neurological toxicity can be managed with steroids, and in the vast majority of patients this resolves, and by the time they're discharged on day 28, this will have settled. Longer term, we're seeing our patients have prolonged cytopenias, and you may well be seeing some of our regular patients having transfusion support. There's also a significant increased risk of infection, not only because some of these patients are neutropenic, but also because of the T cell depletion. Many of these patients will be ending up on IVIG, and again, this is something that will be coming through the day unit. There is also an additional risk of secondary cancers, particularly myelodysplastic syndrome due to all the chemotherapy that's given. And there's also been a recent concern that there may be increased rates of T cell lymphomas in these patients, although this is currently under scrutiny. So in summary, CAR T is an exciting potential option for our patients with hard to treat B-cell lymphoma, B-ALL, and probably in the near future multiple myeloma. It should be noted that the process for CAR T is difficult for patients, and they require multiple tests and investigations, multiple procedures, and a long admission in OUH, which can be difficult psychologically and physically. I would say that CAR T seems to be generally well tolerated, although I suspect if you ask some of our patients who've had this, they may disagree with this statement. Nonetheless, it does remain a promising treatment for some of our patients with the hardest to treat cancers, and I suspect we will be seeing many more of them come through our day unit. Thank you very much for listening.